lecture is non-depolarizing neuromuscular blocking agents and the therapeutic uses of skeletal muscle relaxants. So I will talk in details about the non-depolarizing neuromuscular agents, the classification, the mechanism of action, the pharmacological properties and effects of non-depolarizing neuromuscular blocking agents, and lastly we will discuss the therapeutic uses of skeletal muscle relaxants. The non-depolarizing neuromuscular blocking agents inhibit transmission across the neuromuscular junction, causing relaxation of the skeletal muscle. The non-depolarizing neuromuscular blocking agents can be divided based on the chemical structure and the duration of action. Based on the chemical structure, they can be divided into steroidal derivatives and benzyl isoquinolinium derivatives. The steroidal derivatives include pancuronium, vecuronium, rocuronium, rapacuronium, whereas the benzyl isoquinolinium derivatives include atracurium, mivacurium, doxacurium and so on. The non-depolarizing neuromuscular agents can be also classified based on the duration of action. They can be long-acting, intermediate-acting and short-acting. The long-acting drugs are tubocurarine, galamine, pancuronium, pipecuronium. The intermediate-acting drugs are vecuronium, rocuronium, atracurium, whereas the short-acting drugs are mivacurium, rapacuronium. Coming to the mechanism of action of non-depolarizing neuromuscular blocking agents. As we have learned earlier, the action potential spreads along the alpha motor neuron, causing depolarization of the alpha motor neuron, leading to the opening of the calcium channels, and calcium entry stimulates the release of acetylcholine into the synaptic cleft, which subsequently combines or binds to the nicotinic receptors of the motor end plate, which in turn opens the sodium channels, allowing the entry of sodium ions, causing depolarization of the motor end plate, and this elicits contraction of the skeletal muscles. So how does a non-depolarizing neuromuscular blocker cause relaxation of skeletal muscle? The non-depolarizing neuromuscular blockers such as pancuronium, vecuronium acts as a competitive antagonist of acetylcholine. That is, it competes with acetylcholine for the nicotinic receptor at the motor end plate. So it competes with acetylcholine and binds to the nicotinic receptor and prevents the binding of acetylcholine to the NM receptor at the motor end plate. It acts as an antagonist because it has affinity for the NM receptor but no intrinsic activity. So it has no action of its own. It competes with acetylcholine for the NM receptor at the motor end plate and prevents the binding of acetylcholine, and since the binding of acetylcholine is prevented and blocked, the sodium channels do not open, and this leads to the absence of end plate potential, and the absence of end plate potential leads to absence of contraction of the skeletal muscle or relaxation of the skeletal muscle. And so in this way, a non-depolarizing neuromuscular blocker acts as a competitive antagonist of acetylcholine. Secondly, this type of antagonism is known as the mountable antagonism, which means that by increasing the concentration of acetylcholine, the neuromuscular blocker can be displaced, can be removed from the receptor, and the blockade can be reversed. So this is possible in the presence of anticholinesterases such as neostigmine, pyridostigmine, which increases the concentration of acetylcholine by inhibiting the cholinesterase enzyme that is responsible for the degradation of acetylcholine. So by inhibiting the cholinesterase enzyme that degrades acetylcholine, it increases the concentration of acetylcholine, and acetylcholine displaces the blocker from the receptor, and the blockade can be reversed. Thus, neostigmine and pyridostigmine are administered to terminate the neuromuscular blocking action after the completion of the surgical procedure or in case of overdose of neuromuscular blocker so that the blockade of the neuromuscular junction can be reversed with the help of drugs such as neostigmine and pyridostigmine. Moving on to the pharmacological properties and effects of non-depolarizing neuromuscular blocking agents. On parenteral administration of neuromuscular blocking agents, it shows motor weakness and progressive flaccid paralysis. If we look at the sequence of skeletal muscle paralysis, the fast and smaller muscles are affected first. For example, the eyes, toes, larynx, jaws are affected first. The larger muscles such as the limbs and trunk are affected next. Later, the diaphragm and intercostal muscles are affected. The recovery of the skeletal muscle paralysis occurs in the reverse order, which means that the diaphragm and the intercostal muscles are the first to recover. Consciousness is not affected by the neuromuscular blocking agents. So if we look at the pharmacological properties of non-depolarizing neuromuscular blocking agents, tubocurarine is a prototype drug and other non-depolarizing neuromuscular blocking agents are quaternary compounds, which means that they are polar in nature and they are ionized at physiological pH. Since they are polar in nature, they cannot readily cross the blood-brain barrier, therefore CNS toxicity is less. Also, because they are polar in nature, they do not cross the placental barrier, so they can be used in cesarean section and do not affect the fetus. These drugs have small apparent volume of distribution, which means that they are confined to the extracellular fluid, they are confined to the vascular compartment, which makes these drugs long-acting. In general, the long-acting drugs are more potent, which means that they require lower doses. But the drawback is that the onset of action is delayed with the exception of pipecuronium. It has been seen that the duration of action of these drugs depend on the route of elimination. So how does the route of elimination decide the duration of action? The drugs that are excreted by the kidney have a long duration of action, whereas the drugs that are excreted by the liver have intermediate and shorter duration of action. Then there are certain drugs that are inactivated by plasmacholinesterase enzymes such as mivacurium, and these drugs have a shorter duration of action. However, in case of renal impairment, the duration of action of mivacurium is prolonged because in renal impairment, the plasmacholinesterase enzymes are low. Because of low plasmacholinesterase enzyme, the duration of action of mivacurium is prolonged in renal impairment. Then there are drugs such as atracurium and cisatracurium which undergo Hoffman elimination, which means that they are spontaneously inactivated in the plasma and therefore the duration of action is very short. These drugs are very safe in renal and liver disease because they are inactivated in the plasma and they are not dependent on the liver and kidney for their metabolism. To be noted that atracurium undergoes Hoffman elimination and the breakdown product is laudanosine. It is a CNS stimulant and it can cross the blood-brain barrier and produce CNS toxicity and can produce seizures. Therefore, cisatracurium is better as compared to atracurium because it produces lesser laudanosine, which is a CNS stimulant. Therefore, the CNS side effects are less, the hemodynamic side effects are less, and satisfactory level of neuromuscular blockade can be achieved with cisatracurium. Therefore, cisatracurium is preferred compared to atracurium. Also do remember that atracurium is unstable in alkaline pH. Therefore, in hyperventilation, when there is carbon dioxide washout and there is respiratory alkalosis, it is chemically unstable and the action of atracurium is brief. Also do remember that the drugs that are metabolized in the liver such as vecuronium, rocuronium, rapacuronium produces metabolites that are slowly cleared. Thus, these drugs if given in ICU for several days shows accumulation and prolonged paralysis. So now let's talk about the effects of non-depolarizing neuromuscular blocking agents other than skeletal muscle paralysis. These drugs have a tendency to release histamine histamine from the mast cells. The benzyl isoquinoline derivative such as tubocurarine has highest tendency to release histamine. Other drugs such as mivacurium, doxacurium, atracurium has lesser tendency to release histamine. They release histamine to a lesser extent. Steroidal derivatives such as pancuronium, vecuronium, rocuronium have least histamine releasing property. The next property is blockade of ganglion and blockade of cardiac receptors, that is M2 muscarinic receptors. At common clinical doses, it has been observed that tubocurarine partially blocks the autonomic ganglia and this can cause hypotension. Tubocurarine also has the highest tendency to release histamine. So because of release of histamine and blockade of autonomic ganglia, there can be hypotension which is seen as an adverse effect. Other drugs such as mivacurium, doxacurium, atracurium produce least ganglionic blocking activity. So they can only block the ganglion at higher doses. The advantage of steroidal derivatives such as pancuronium, rocuronium, vecuronium is that they do not block autonomic ganglia and therefore hypotension does not occur as a side effect. To be noted that pancuronium has vagolytic activity. It can block the cardiac M2 receptors and this can cause tachycardia as a side effect. Thus, pancuronium causes tachycardia and drugs such as tubocurarine can produce hypotension. So, going deeper into the effects of skeletal muscle paralysis, hypoxia or respiratory paralysis can occur as a side effect because of prolonged paralysis. In such circumstances, neostigmine or pyridostigmine can be used to reverse the neuromuscular blockade action. But the disadvantage of neostigmine is that it increases the concentration of acetylcholine by inhibiting cholinesterase enzyme. And because of increased cholinergic stimulation, there can be bronchospasm, bradycardia and hypotension. So these side effects can be caused by the neostigmine and pyridostigmine and therefore atropine can be administered to counteract excessive muscarinic stimulation. In addition, sympathomimetics can be given to support blood pressure and antihistaminics can counteract the responses following excessive histamine release. Coming to the cardiovascular effect, as we have discussed earlier, hypotension can be caused by tubocurarine because of ganglion blocking activity and release of histamine. Pancuronium can cause tachycardia as a side effect. With respect to respiratory effects, bronchospasm can be caused by tubocurarine. In the GI tract, there is decrease in the tone and motility of the intestine and this can cause constipation as a side effect. Thus, adverse effects can be caused by extension of pharmacological effects such as skeletal muscle paralysis causing hypoxia and respiratory paralysis as a side effect. In addition, pharmacological properties such as release of histamine from the mast cells, ganglion blocking activity, blockade of muscarinic receptors or vagolytic action can cause additional side effects. Moving on to the therapeutic uses of neuromuscular blocking drugs. These drugs can be used as an adjuvant to general anesthesia during surgical procedures. The selection of the drug depends on the onset of action, the duration of blockade required, and the patient's renal, liver status, hemodynamic status. For example, for brief procedures such as endotracheal intubation, bronchoscopy, laryngoscopy, mivacurium or succinylcholine is preferred. For longer surgical procedures, pipecuronium, vecuronium, pancuronium have a longer or intermediate duration of action and are preferred drugs. Atracurium is considered to be a safe drug in patients with renal or liver disease. In patients with renal impairment, rocuronium is the preferred drug as it is metabolized in the liver. Secondly, non-depolarizing blockers can be used to prevent trauma during electroconvulsive therapy. So these drugs can be used to prevent injuries and fractures due to excessive convulsions from electroconvulsive therapy. These drugs can be used in spastic conditions such as tetanus or status epilepticus, where succinylcholine is used along with diazepam. Lastly, neuromuscular blocking agents can be used to control ventilation. So these drugs can be used to aid ventilation in obstructive airway diseases as they reduce the chest wall resistance and increase the airway flow. This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.